Now, as you can tell from the title of my talk, within the next 45 minutes, I'd like to cover neuroendocrine neoplasms of the pancreas, which is a topic that has confused many pathologists, including experts, because of the constant changes in nomenclature, classification systems, grading schemes, and even the AJCC TNM staging system. To address these issues, I'd like to start off with a case presentation and then segue into the epidemiology, nomenclature, and clinical pathologic features of the major pancreatic neuroendocrine neoplasms. Further, it's important to discuss why and how these neoplasms need to be distinguished, including their associated molecular findings. And finally, I'd like to discuss other diagnostic entities that can also arise or secondarily involve the pancreas and may mimic these neoplasms. So let's start with a 78-year-old female complaining of abdominal pain. She also noticed she had dark urine and her skin was yellow. Laboratory tests were ordered and demonstrated elevations in both liver transaminases and pancreatic enzymes. Because of her symptoms and elevated lab values, she emergently underwent a magnetic resonance cholangiopancreatography, or MRCP, to evaluate her pancreas, bile duct, and liver. The MRCP identified a contrast-filling defect within the distal common bile duct that corresponded to a bile duct stricture, as indicated by the yellow arrow. A stent was placed across the stricture to keep the bile duct patent, and the patient underwent further imaging that included a CT scan, which demonstrated a large pancreatic head mass, and it measured about 5.6 centimeters in greatest dimension. An FNA of the pancreas was performed, and a diagnosis of positive for carcinoma was rendered, but the cytopathology material could not be further subtyped. The patient, however, was a good surgical candidate and underwent a classic pancreatic duodenectomy, or Whipple procedure. As with all of our Whipple specimens, we cut the pancreas along the duct, specifically the pancreatic duct and the bile duct. The bile duct is indicated at the top and the pancreatic duct is to the left. As shown here, the pancreatic duct was completely obliterated by a large mass that again measured 5.6 centimeters in greatest dimension, encompassing almost the entire pancreatic head. Histologically, the mass was centered within the pancreas and composed of closely packed neoplastic cells with little intervening stroma. At higher magnification, the neoplastic cells were organized in a nested architecture and composed of monotonous cells with stippled or somewhat salt and pepper nuclei and granular eosinophilic cytoplasm. A limited histochemical panel was performed and demonstrated diffuse immunolabeling for cytokeratins, as well as both synaptophysin and chromogranin. Finally, immunolabeling for Ki67 demonstrated a high proliferation index of 24%. Now, when approaching a pancreatic lesion, I like to apply a systematic or algorithmic approach with the first decision tree based on whether the lesion is solid or cystic in nature. And among the solid lesions, the differential diagnosis includes 6 neoplasms and an important benign entity, specifically chronic pancreatitis. Of course, the topic for today is not pancreatic ductal adenocarcinoma, which is a lecture in itself, but instead neuroendocrine neoplasms of the pancreas, specifically well-differentiated neuroendocrine tumors and poorly differentiated neuroendocrine carcinomas. However, it's probably worthwhile to put these neoplasms in perspective. In comparison to pancreatic ductal adenocarcinoma, pancreatic neuroendocrine neoplasms are the second most common neoplasm of the pancreas. They're also the third most common neuroendocrine neoplasm of the gastroenteropancreatic system, with the first and second spots going to the ileum and rectum. Now, most lay people are unaware of pancreatic neuroendocrine neoplasms, and that's because the majority of patients have a protracted clinical disease course. For example, in the case of Steve Jobs, Irfan Khan, and Aretha Franklin, many of these celebrities were diagnosed years before they succumbed to their disease. In fact, Steve Jobs actually underwent liver transplantation in order to try to extend his life and decrease his metastatic tumor burden, which unfortunately was not successful. Nevertheless, the 5-year survival for pancreatic neuroendocrine neoplasms has improved over the years and hovers around 65%, and almost half these patients live past 10 years. Pancreatic neuroendocrine neoplasms are considered a rare disease, and in the United States, the incidence is approximately 3,000 patients per year. But it's projected that there will be a significant increase in the number of new cases over the next 5 years, likely due to incidental and indolent lesions being picked up with increasing use of radiographic imaging. Now, before continuing on to the clinical pathologic features of these neoplasms, it's important to make sure we're all on the same page regarding terminology. For example, the term differentiation, which can be a little confusing. To put it simply, differentiation refers to the extent a neoplasm resembles its non-neoplastic counterpart. For example, in the case of a pancreatic neuroendocrine neoplasm, does the neoplasm resemble the islets of Langerhans, or does it not? Pancreatic neuroendocrine neoplasms can be subdivided into two main categories of differentiation: well-differentiated neuroendocrine tumors and poorly differentiated neuroendocrine carcinomas. There is no middle category. Well-differentiated pancreatic neuroendocrine tumors are referred to as PNETs and resemble the islets of Langerhans. And poorly differentiated neuroendocrine carcinomas, or PANECs, typically do not resemble the islets of Langerhans. Differentiation, however, should not be confused with histologic grade. Although we often use these terms interchangeably for other gastrointestinal tract tumors, specifically adenocarcinoma, both terms refer to something very different when it comes to neuroendocrine neoplasms. Histologic grade is an indicator of regression, or how quickly the pancreatic neuroendocrine neoplasm, is likely to grow and spread. In contrast to prior editions of the WHO, the 2022 WHO system assigns histologic grade to only pancreatic neuroendocrine tumors. Previously, we would assign grade to pancreatic neuroendocrine carcinomas, but this is no longer done as they're always a high-grade malignancy. As far as WHO histologic grades, there are three, 1 through 3, which is based on tumor proliferation index using mitotic count and Ki67 immunolabeling. Again, differentiation and histologic grade are separate variables, with differentiation referring to morphology and histologic grade to proliferation index. Now, by far, most neuroendocrine neoplasms of the pancreas are well-differentiated pancreatic neuroendocrine tumors. These neoplasms are defined as a malignant neoplasm arising from the islets of Langerhans and greater than or equal to 0.5 centimeters. Patients can present with a PNET at any age. However, younger patients are usually syndromic, such as those with MEN1 or MEN1 syndrome. In addition, clinical symptoms can vary independent on whether the neoplasm is functional or non-functional. Whether a PNET is functional or non-functional refers to whether the tumor is secreting hormones typically reserved for islets of Langerhans. For example, production of insulin by an insulinoma that consequently results in symptoms associated with hypoglycemia. Historically, PNETs often came to present clinical presentation due to their associated symptoms, so the prevalence of functional PNETs was higher than non-functional PNETs. And it would be expected, due to the lack of symptoms, non-functional PNETs often presented as large, bulky tumors with invasion into adjacent organs and distant metastasis. Thus, outcome for non-functional PNETs historically was horrible as compared to functional PNETs. However, in recent years, with improvements in radiographic imaging, incidental non-functional PNETs have substantially increased in prevalence, and as a result, these tumors are diagnosed at a much earlier pathologic stage. Thus, patient outcome for non-functional PNETs has improved dramatically as compared to functional PNETs. Grossly pancreatic neuroendocrine tumors are frequently tan to brown in color and are clearly demarcated from the surrounding uninvolved pancreatic parenchyma. But in some cases, they can be densely sclerotic and infiltrative. These neoplasms can vary in size from small to quite large, and in fact, size is considered an important prognostic feature. Other poor prognostic findings include venous invasion, as seen here, where the patient's tumor is within the splenic vein, and they can invade other organs, like the spleen. Interestingly, approximately 10% of PNETs can present with a cystic component, which are referred to as a cystic pancreatic neuroendocrine tumor and often associated with MEN1 syndrome. Microscopically, these neoplasms are often walled off or encapsulated from the uninvolved parenchyma by a band of fibrosis and arranged in multiple organoid growth patterns that include nests, trabecula that appear as ribbons, gyroform configuration of internastomosing cords, and sometimes a sclerotic appearance with significant intervening fibrosis that can secondarily cause pancreatic duct obstruction and destruction of the pancreatic ducts thereafter. However, despite the variety of organoid patterns, all PNETs show similar cytologic features that are characterized by an eosinophilic granular cytoplasm and stippled or salt and pepper nuclei. Except for one variant, specifically the clear cell variant of pancreatic neuroendocrine tumors that exhibits abundant clear cytoplasm and may mimic a renal cell carcinoma. Hence, demonstration of neuroendocrine differentiation is essential to making the diagnosis of a pancreatic neuroendocrine tumor using immunohistochemical stains such as synaptophysin and chromogram. Now, I do want to underscore the WHO criteria for a PNET requires a size of at least 0.5 centimeters, which then begs the question, what about PNETs less than 0.5 centimeters? Well, those neoplasms less than 0.5 centimeters are referred to as a pancreatic neuroendocrine microadenoma and are considered precursor neoplasms to PNETs. Neuroendocrine microadenomas represent a clonal outgrowth from a single islet of Langerhans. In the case pictured here, a glucagon-expressing alpha cell within a single islet has started to clonally proliferate into a microadenoma. This proliferation contrasts that of a normal islet at the bottom right, as designated by the red arrow, which shows mixed expression for both glucagon and insulin. Poorly differentiated neuroendocrine carcinomas are rare neoplasms of the pancreas, and their origin is unclear. The general thought is that these neoplasms do not arise from the islets of Langerhans, but rather represent transdifferentiation from the exocrine pancreas, such as the ducts or acin or parenchyma. In support of this hypothesis, these patients often present with similar clinical symptoms that include obstructive jaundice, weight loss, and elevated serum markers for CA19-9 as those seen with exocrine pancreatic malignancies. Grossly, these neoplasms are indistinguishable from pancreatic ductal adenocarcinoma or acinar cell carcinoma. But microscopically, they can be subdivided into two types, small cell and large cell carcinoma, akin to the same terminology and somewhat same definition used to describe neuroendocrine carcinomas of pulmonary origin. Small cell carcinomas present as sheets or nests of small cells with hyperchromatic and molding nuclei. There may be areas of confluent necrosis, extensive apoptosis, or death, and obviously abundant mitotic figures. Large cell carcinoma have larger, round, vesicular nuclei that can form an organoid growth pattern very similar to well-differentiated neuroendocrine tumors, but these carcinomas have abundant apoptotic cells and certainly a significant number of mitotic figures. Now, in addition to determining differentiation, I mentioned the concept of histologic grade. In previous editions of the WHO and HACC, histologic grade was assigned to both well-differentiated pancreatic neuroendocrine tumors and poorly differentiated pancreatic neuroendocrine carcinomas. However, in 2017, the WHO removed the histologic grade from poorly differentiated neuroendocrine carcinomas. Histologic grade is strictly for well-differentiated pancreatic neuroendocrine tumors and categorized using a combination of both Ki67 and mitotic figures. Of note, mitotic count should be measured by evaluating an area of 10 millimeters squared, but only reported as per 2 millimeters squared. So why don't we go through a few examples of histologic grades? This would be a grade 1 PNET, which is characterized by a Ki67 of less than 3% and a mitotic count of less than 2 per 2 millimeters squared. Grade 2 PNETs have a Ki67 index between 3 and 20%, or a mitotic count between 2 and 20 per 2 millimeters squared. And then grade 3 PNETs are classified based on Ki67 index greater than 20%, or mitotic count of greater than 20 per 2 millimeters squared. Now, all of this is easier said than done. The real issues arise when you are near the cutoffs for each of the histologic grades, especially for Ki67. And unfortunately, a precise method for Ki67 assessment has not been standardized. The College of American Pathologists, however, does outline a number of methods that have been used to evaluate Ki67. For example, some investigators have advocated that it's sufficient to report an eyeball estimate for Ki67, but this should not be done for cases approaching specific cutoffs, as objective quantitation of Ki67 is associated with significant margin of error, especially for pathologists that do not routinely score Ki67 in practice. Others have gone to the other extreme, where they are utilizing automated digital analysis. This relies on expensive equipment and creation of complex algorithmic software to subtract the non-neoplastic cells, debris, and junk from the tumor cells that are present. In our own experience, we have tried for years to get this to work and finally have, but it's certainly taking an extensive amount of time, requires a digital platform, and somewhat of an artificial intelligence interface. What has shown promise, probably best in clinical practice, is manual counting of camera-captured images. It's quick, inexpensive. You can do it with your cell phone if you like. It's feasible in a busy practice itself and highly accurate with high inter-observer agreement. Using this method, a minimum of 500 tumor cells should be counted to determine the Ki67 index. And if there are less than 500 tumor cells, a comment should be made that less was evaluated. If evaluating biopsies, our practice is to add another comment that grading has not been completely validated within biopsies on these types of specimens, and thus prone to sampling issues. Finally, there will be cases where Ki67 and mitotic counts are discordant in histologic grade. And in these scenarios, it is recommended to assign the higher grade. And usually the categorization of a higher grade is based on the Ki67 index rather than the mitotic count. While I know histologic grade can be bothersome, its standardization has provided important prognostic information, as well as aided clinicians in stratifying patients for specific treatments. For example, patients with grade 1 and grade 2 PNETs are more likely to respond to mTOR inhibitors, while grade 3 PNETs typically do not, and a little more often usually are given more aggressive courses of chemo. In contrast, grade 3 PNETs have shown improved responses, actually, in fact, to etoposide maybe or capecitabine as compared to grade 1 and 2 tumors. However, probably the most clinically relevant distinction has to be between grade 3 well-differentiated pancreatic neuroendocrine tumors and a poorly differentiated pancreatic neuroendocrine carcinoma. Patients with resectable, well-differentiated PNETs respond well to surgical intervention with curative intent. And those patients with locally advanced or metastatic disease, medical therapy is the mainstay of treatment, which would include somatostatin analogs, sometimes mTOR inhibitors, alkylating agents, and peptide receptor radionucleotide therapy, or SSTR2 inhibitors. In contrast, poorly differentiated PNETs do not respond to these therapeutic interventions, and instead often respond to therapy that we can give patients for pancreatic ductal adenocarcinoma, specifically platinum-based regimens and or radiation. Moreover, there is a difference in prognosis between G3 well-differentiated PNETs and poorly differentiated PNETs. Patients with G3 well-differentiated neuroendocrine tumors, as seen in blue, seem to fare better than patients with a poorly differentiated neuroendocrine carcinoma in red. Thus, considering the differences in treatment, differences in survival, it's important to distinguish G3 well-differentiated neuroendocrine tumors from poorly differentiated neuroendocrine carcinomas. The problem, however, is the distinction between these two entities can certainly be challenging. Many G3 well-differentiated pancreatic neuroendocrine tumors that again should resemble the islets of Langerhans can demonstrate overlapping histologic features with poorly differentiated pancreatic neuroendocrine carcinomas. For these cases, without additional data other than just the H&E, one cannot really tell which is a neuroendocrine tumor and which is a neuroendocrine carcinoma. But there are some helpful clues, as far as clinical information, pathologic findings, and ancillary studies that can help delineate between these two entities. The clinical features that would favor a grade 3 well-differentiated neuroendocrine tumor would be an incidental presentation with elevated serum chromogranin A levels. In contrast, patients with a poorly differentiated neuroendocrine carcinoma often present with abdominal pain, jaundice, weight loss, pancreatitis, and or diabetes. As far as, new onset diabetes. As far as serum studies, neuroendocrine carcinomas often are remarkable for an elevated serum CA19-9 or even CEA, again, very similar to patients with pancreatic ductal adenocarcinoma. In addition to clinical presentation, I cannot stress enough the importance of a thorough pathologic examination. Poorly differentiated neuroendocrine carcinomas do not arise from a low-grade component, while grade 3 well-differentiated neuroendocrine tumors often do, and therefore adequate sampling is important. This, of course, can be difficult when dealing with biopsies, but if the patient had a prior pathologic specimen exhibiting a low-grade pancreatic neuroendocrine tumor, that would support a tumor rather than a carcinoma. And lastly, for those that have access to them, I find the limited immunohistochemical panel or even molecular studies to be extremely helpful. When it comes to a immunohistochemical panel, I typically use 4 different antibodies. ATRX, DAX, RB, and P53 have been very helpful in distinguishing between grade 3 pancreatic neuroendocrine tumors and pancreatic neuroendocrine carcinomas. The basis for the immunostains, DAX, ATRX, P53, and RB, is from whole exome and whole genome sequencing results, where distinct genomic alterations were found in both neoplasms. For example, recurrent genomic alterations in the genes DAX and ATRX are exclusively present in well-differentiated neuroendocrine tumors, while RB and P53 are almost always only present in poorly differentiated neuroendocrine carcinomas. Moreover, in a recent study, our group has just completed and about to be published we performed targeted sequencing on over 800 pancreatic neuroendocrine neoplasms that includes over 100 pancreatic neuroendocrine carcinomas. Consistent with prior studies, genomic alterations in DAX and ATRX were highly specific for pancreatic neuroendocrine tumors, especially WHO grade 3 PNETs, while pancreatic neuroendocrine carcinomas were characterized by recurrent alterations in not only p53RB, but also KRAS and P16 or CDKN2A. Of course, targeted sequencing for these genes may not be feasible at all centers due to access and costs associated with the sequencing itself, but these alterations do represent a subsequent loss of their corresponding protein expression, which can be used as a surrogate. So going back to those two cases of pancreatic neuroendocrine neoplasms, we performed immunochemical stains for the gene ATRX, which once again is lost preferentially in grade 3 well-differentiated neuroendocrine tumors as opposed to poorly differentiated neuroendocrine carcinomas. ATRX is a nuclear protein and relatively easy to interpret. I'm sure many of your neuropathology colleagues are using it for diagnostic classification of gliomas. The case on the left clearly exhibits loss of ATRX within the neoplastic nuclei and retained expression in the stroma, while the case on the right has retained expression within both the neoplastic nuclei and stroma. Therefore, this case on the left is consistent with a well-differentiated pancreatic neuroendocrine tumor. Unfortunately, not all pancreatic neuroendocrine tumors will demonstrate loss of expression for ATRX or DAX. It's a specific antibody or basically a specific biomarker, but it's not 100% sensitive. So the case on the right is still somewhat unclear if it should be classified as a tumor or a carcinoma. And that's where another set of immunostains may be helpful. Similar to ATRX, RB is a nuclear stain, but preferentially lost in poorly differentiated neuroendocrine carcinomas. Once again, the supporting stroma serves as an internal control, and it's relatively easy to interpret that the case on the right is the neuroendocrine neoplasm that shows loss of expression, and therefore consistent with a poorly differentiated neuroendocrine carcinoma, and for this, it would be categorized as a large cell type. Using a limited immunopanel of ATRX and RB, as well as DAX and P53, can be extremely helpful in distinguishing between grade 3 neuroendocrine tumors and neuroendocrine carcinomas of the pancreas. However, these proteins, again, are not lost in every well-differentiated neuroendocrine tumor or every poorly differentiated neuroendocrine carcinoma. Therefore, in my opinion, they should be used to support your presumptive diagnosis on the basis of the patient's clinical presentation and histologic findings. Now, that being said, rendering a diagnosis of a well-differentiated pancreatic neuroendocrine tumor or a poorly differentiated pancreatic neuroendocrine carcinoma is really just half the battle. The next step is staging the neoplasm. Poorly differentiated neuroendocrine carcinomas are easy to remember, in my opinion, as they are staged similar to pancreatic ductal adenocarcinoma, as well as other exocrine malignancies of the pancreas like acinar cell carcinoma. In contrast, well-differentiated pancreatic neuroendocrine tumors are not staged as an exocrine pancreatic neoplasm, which was new for the 8th edition of the AJCC staging system that came out now 4 or 5 years ago. Instead, pancreatic neuroendocrine tumors have their own staging system, which is honestly isn't all too different from the exocrine pancreas. Again, just like the exocrine pancreas, size matters when it comes to T staging. Pathologic T staging is subdivided based on cutoffs of 2 and 4 centimeters, but there are subtle differences at that 2 centimeter cutoff when it comes to comparing endocrine and exocrine neoplasms, specifically deciding between the T1 and T2 stages. The justification for this difference between the exocrine and endocrine neoplasms, as shown here, is that 2 centimeter mark for a pancreatic neuroendocrine tumor is a decision point for many of our surgeons, as based on the NCCN guidelines in the United States, NANETS guidelines, as well as ENETS guidelines. A surgeon has the option to survey a patient considering an incidental lesions are on the rise if they are less than 2 centimeters, and it may follow an indolent course. However, if they're above 2 centimeters, that seems to be the tipping point for when to recommend surgical intervention, as these neoplasms have a higher incidence of distant metastasis, especially among larger tumors. Additional differences between endocrine and exocrine neoplasms include invasion into surrounding organs. Other than being larger than 4 centimeters, a T3 pancreatic neuroendocrine tumor is also defined as invading into the duodenum or the extrapancreatic common bile duct. In comparison, T4 not only includes the major vessels as the celiac axis and SMA or superior mesenteric artery, but invasion into adjacent organs other than the duodenum, such as the stomach, spleen, adrenal gland, kidneys, and others. So let's review the staging system for well-differentiated pancreatic neuroendocrine tumors. A pathologic T1 panet is less than 2 centimeters or smaller than a peanut and confined to the pancreas. A T2 neuroendocrine tumor is defined as between 2 to 4 centimeters in size, or maybe the size of a walnut, but again confined to the pancreatic parenchyma. In contrast, a T3 neuroendocrine tumor is greater than 4 centimeters or extends out of the pancreas to involve the duodenum, as seen here, or the extrapancreatic common bile duct, not the intrapancreatic common bile duct, which would still be considered part of the T1 or T2 category based on size, or T3 in general. Lastly, a T4 neuroendocrine tumor invades the major vessels around the pancreas that include the celiac axis and the superior mesenteric artery, but not the common hepatic artery, which is oddly different from pancreatic ductal adenocarcinoma staging system. A T4 neoplasm could also include invasion into the spleen, as shown here, as well as the stomach, adrenal gland, and so on. End staging is simply the absence or presence of regional lymph node metastasis, and M1 staging is currently subdivided into 3 subcategories based on involvement of the liver. The 8th edition now subclassifies the M1 stage as either confined to the liver, outside the liver, or involving both, by using the designations M1A, M1B, and M1C respectively. This 3-tiered M1 staging system is universally used among all gastroenteropancreatic neuroendocrine tumors. But really, what is the point of evaluating a panet for Ki-67 index, WHO grade, tumor size, tumor stage, and other pathologic features such as lymphovascular and perineural invasion? Well, in effect, we're all trying to determine the prognosis of the neuroendocrine tumor itself. But all of these parameters that I've listed here are really indirect measurements of the tumor and don't actually reflect their pathobiology. Certainly, you have grade 1 neuroendocrine tumors that can metastasize out of the pancreas. And so it'd be advantageous to identify true markers that really get at the heart of the pathobiology of these neoplasms and understanding their true biologic nature. And hence the study of identifying new biomarkers for when it comes to pancreatic neuroendocrine tumors. Now, not surprisingly, I mentioned DAX and ATRX, which, based on our understanding, can be highly sensitive and specific for these tumors as opposed to neuroendocrine carcinomas. But not surprisingly, these markers can also be used as a prognostic biomarker as well. Interestingly, both DAX and ATRX, when they're lost, it leads to a creation of alternative lengthening of telomeres, which results in large telomeres within the tumor itself. It's been well studied in sarcomas and is actually considered a poor prognostic finding. But the question that we and others have had is, can we use these to understand the prognosis of neuroendocrine tumors as a whole? And so we and other groups have evaluated hundreds and hundreds of neuroendocrine tumors, primary neoplasms, and followed these patients over the course of time based on their status of ATRX and DAX as an observational clinical trial. And what we found is that when panets lose DAX or ATRX, patients have a shorter disease-free survival, meaning they do often present with metastatic disease. And they have a shorter disease-specific survival, meaning their survival itself is significantly decreased as those with patients that have panets that have preserved staining for ATRX and DAX. Not surprisingly, DAX and ATRX also coincide with several adverse clinical pathologic features like WHO grade, tumor size, and obviously the presence of synchronous and distant metachronous distant metastasis. These biomarkers can be used on cytopathology specimens, and something that is being evaluated in our cohorts right now, as well as in other studies that are ongoing. Now, I've gone through several concepts: nomenclature, pathologic finding, staging, and stage, but I'm not done yet. But this is a good time for just really a brief summary or recap. And so I'd just like to go through that really briefly. First, the differences between differentiation and histologic grade. Again, differentiation refers to the extent of a neoplasm resembling its non-neoplastic counterpart, while histologic grade is strictly for well-differentiated pancreatic neuroendocrine tumors. Remember, it is clinically important to distinguish a G3 neuroendocrine tumor and a neuroendocrine carcinoma, which requires consideration of not only pathologic findings, but clinical and ancillary studies. Third, there are some notable aspects to the TNM staging for pancreatic neuroendocrine tumors. In fact, they've got their own staging system. In addition, and somewhat in my opinion, be on the lookout for these routine stains, DAX and ATRX. Although I guess for the most part, many labs don't have them on hand, I do find that it's expanding, and they can be used as a helpful biomarker to discern between G3 PNETs and neuroendocrine carcinomas, and potentially as prognostic biomarkers in the future, in the very near future. And finally, I haven't mentioned this entity just yet, but it should be no surprise to anyone that mixed neoplasms do occur in the pancreas, and mixed neoplasms are now by the WHO called mixed neuroendocrine non-neuroendocrine neoplasms, which is really, unfortunately, a horrible name in my personal opinion, but it's defined as at least 30% of either component. The mixed component that's non-neuroendocrine could be either ductal or acinar. And these mixed neoplasms, for the most part, the neuroendocrine component is often a high-grade malignancy, so typically a poorly differentiated neuroendocrine carcinoma. Of course, more data is needed to understand the actual pathobiology of mixed neuroendocrine, non-neuroendocrine neoplasms, from which they arise as far as cell origin, and many of those genetic and RNA now based studies are ongoing. Now, before returning to our clinical vignette, I would also like to briefly review the differential diagnosis for neuroendocrine neoplasms of the pancreas, and therefore completing our list of really solid lesions of the pancreas, except for adenocarcinoma. First, solid pseudopapillary neoplasms, which can be solid and or cystic. These are low-grade malignant epithelial neoplasms of unknown origin. They are rare and predominantly occur in young females with a mean age of 25 years of age. Similar to pancreatic neuroendocrine tumors, they are often well demarcated and solitary. Excuse me, I'm sorry, kind of passed through that fast. Microscopically, solid pseudopapillary neoplasms have an insidious growth pattern extending through and around the normal pancreatic parenchyma, which contrasts well-differentiated pancreatic neuroendocrine tumors that are often well circumscribed and separated from the uninvolved pancreatic parenchyma by bands of fibrosis. At a higher magnification, the neoplastic cells of a solid pseudopapillary neoplasm are discohesive and polarized around thin, delicate vessels. A well-known feature of these neoplasms is the presence of intracytoplasmic and extracellular hyaline globules. However, hyaline globules have been well reported in neuroendocrine tumors as well. Therefore, utilizing this feature alone as a specific marker of solid pseudopapillary neoplasms will lead you down the wrong path, unfortunately. What I do, or what at least I find most helpful in performing, in making a diagnosis of a solid pseudopapillary neoplasm, is performing a scrape preparation at the time the specimen is resected, when it's really fresh out of the OR and hasn't touched formalin just yet. Scraping a solid pseudopapillary neoplasm and staining the slides with a quick H&E demonstrates a beautiful branching solid pseudopapillary pattern of neoplastic cells polarized around a thin-walled vessel. In addition, many of the neoplastic cells are free-floating, discohesive, and plasmacytoid in appearance. This contrasts neuroendocrine neoplasms, which show sheets of neoplastic cells rather than papillary configurations with stippled or salt and pepper nuclei. But they too have a plasmacytoid appearance, so cytologic findings alone may be insufficient to separate these two entities. And one of the most helpful findings is the presence of actually mutations in CTNB1 or beta-catenin, which is for the most part a universal feature of solid pseudopapillary neoplasms. In contrast, pancreatic neuroendocrine tumors are typically absent for these alterations, and therefore beta-catenin can be used to help distinguish between the two neoplasms, with PNETs exhibiting membranous staining, while solid pseudopapillary neoplasms have beautiful nuclear staining. And since beta-catenin is not expressed with the nuclei pancreatic neuroendocrine tumors, LEF1 is also completely absent in these tumors as well. Acinar cell carcinomas can also enter the differential diagnosis for pancreatic neuroendocrine neoplasms, primarily poorly differentiated neuroendocrine carcinomas. An acinar cell carcinoma is a malignant epithelial neoplasm that resembles their cell of origin, acinar cells, and shows evidence of exocrine enzyme production such as trypsin, chymotrypsin, and lipase. These are rare but aggressive malignancies that typically affect older males. Approximately 10% of patients will also present with what looks like peripheral bruising. In fact, their bodies look like they've been in a horrible fight. But this finding reflects what is known as lipase hypersecretion syndrome due to the neoplasm releasing lipase into the bloodstream, which then starts digesting tissue at the end of the peripheral arterioles and thin-walled capillaries. In other words, you can think of this as peripheral fat necrosis. These tumors are often large or massive, easily averaging 5 to 10 centimeters in greatest dimension when they come to presentation. It amazes me how big they can get, but by the time they do come to presentation, they are frequently found in the body and tail of the pancreas rather than the head, but can diffusely involve the pancreas as acinar cell carcinomas invade the pancreatic ductal system and can spread even like a main duct IPMN. Microscopically, acinar cell carcinomas are highly cellular neoplasms that form nodules of tumor cells and lack a desmoplastic stromal response. The presence of a prominent single nucleolus is a characteristic finding of an acinar cell carcinoma and a helpful clue to the diagnosis. In addition, the mitotic rate of these neoplasms can be variable, but more than often quite high. Trypsin, chymotrypsin, lipase, and the new immunostain on the block, BCL10, are all very sensitive and specific markers to confirm the diagnosis of a pancreatic acinar cell carcinoma. The 5-year survival of patients with an acinar cell carcinoma is poor and sadly rivals pancreatic ductal adenocarcinoma. Most acinar cell carcinomas are identified in advanced stage, but a silver lining in these neoplasms is that they harbor frequent fusion genes such as those in BRAF, RAF1, and RET, which are all considered to be targetable from an oncologic perspective. Pancreatoblastomas are another, albeit extremely rare, exocrine neoplasm characterized by both acinar differentiation and unique squamoid corpuscles. These neoplasms have a bimodal age distribution, with 2/3 occurring in children, 1/3 in adults. Interestingly, children with pancreatoblastomas have a much better 5-year survival, 5-year prognosis than adults, suggesting the disease process in these two patient populations may be inherently different. Like acinar cell carcinomas, pancreatoblastomas tend to be large, bulky tumors on gross examination and are also very cellular. Pancreatoblastomas are organized into lobules separated by variable stromal bands. As I mentioned previously, squamoid corpuscles or nests are the histologic hallmark of pancreatoblastomas and are composed of loose aggregates of large spindle-shaped cells or frank squamous differentiation with or without keratinization. Further, the nuclei of these cells display optical clearing due to the accumulation of biotin. Trypsin, chymotrypsin, and or lipase are once again positive within these neoplasms, and hence why they are classified as an exocrine neoplasm and considered to be of acinar cell origin. Moreover, the genetics of pancreatoblastomas parallels acinar cell carcinomas with frequent alterations that include fusion genes, as well as something a little more unique, which are BRCA alterations. Finally, I'd like to round up this session with a few slides on the differential diagnosis for a clear cell variant of pancreatic neuroendocrine tumors. Since they have a stark contrast to conventional pancreatic neuroendocrine tumors, the cytoplasmic clearing in these neoplasms is due to glycogen accumulation, and therefore a serous adenoma may come to mind. Just a bit of review. I know that many of you probably already know what serous adenomas are, but they're benign cystic neoplasms with little to no malignant potential. But a subset of cases can exhibit a truly solid growth pattern that can mimic a neuroendocrine tumor from a gross perspective and even a microscopic perspective when it comes to clear cell variant of a pancreatic neuroendocrine tumor, because they're also filled with rich, clear glycogen-rich cytoplasm and hyperchromatic nuclei. Immunochemical stains are your best friend for these cases, as serous adenomas are negative for neuroendocrine markers like synapto and chromo, while positive for other markers that reflect serous adenoma pathobiology, that being VHL alterations, that includes GLUT1 and inhibin A. And as I mentioned, also, because of those VHL alterations, you can evaluate them molecularly as well. In addition to solid serous adenomas, it's also worth noting that sometimes a well-differentiated neuroendocrine tumor isn't always a well-differentiated neuroendocrine tumor. Of course, at low magnification, in this case, one can appreciate the trabecular organization of this neoplasm. Certainly, there are many aspects of this neoplasm that are consistent with a well-differentiated neuroendocrine tumor. But if you look at the left side, you'll see a little bit of a cystic component, and that's an intermingling of actually a cyst that has serous-type fluid that is partly a serous cystadenoma. And so this neoplasm itself is a mixed neuroendocrine, non-neuroendocrine neoplasm, in this case, a mixed serous cell neuroendocrine neoplasm with it's a neuroendocrine component itself. Not a really well-defined entity from the 2019 or the 2022 WHO, but it still follows the Minin rules of having at least 30% cell lineage. Now, of course, when it comes to glycogen-rich neoplasms, you can't forget about a clear cell renal cell carcinoma. Metastatic RCC is one of the most common neoplasms metastasized to the pancreas. The three most common metastatic neoplasms include lung cancer, renal cell carcinoma, and malignant melanoma. Metastasis from an RCC can actually be occult or remote in history. Metastatic RCC can be solitary or present as multiple deposits. Uncut section, they're well demarcated with a variegated yellow to golden appearance and sometimes show focal calcification. Histologically, these neoplasms are separated from the uninvolved pancreatic parenchyma, similar to a well-differentiated neuroendocrine tumor, by a fibrous capsule of variable thickness. Just like a clear cell neuroendocrine tumor can have a prominent clearing of the cytoplasm. However, they often have blood lakes, and neoplastic cells are really embedded within these multiple patches of blood lakes that are typically seen in metastatic RCC and not clear cell neuroendocrine tumor. But again, that being said, they can have, at least when it comes to metastatic RCC, they can have more uniform areas of just cellular sheets of neoplastic cells that can even have a granular eosinophilic cytoplasm. Again, immunohistochemistry can be very helpful with a panel of stains to include a monoclonal paxate, not a polyclonal paxate, as well as synaptophysin. Monoclonal paxate is very important because polyclonal paxate can cross-react with PAX6, and PAX6 is normally found in the islets of Langerhans, normally expressed in the islets of Langerhans, as well as in the pancreatic neuroendocrine tumors. So, in the time that I have left, in the few minutes I have left, I'd like to go back to our case presentation, which was again a 78-year-old female who presented with a bile duct obstruction and a pancreatic head mass that was resected and found to be 5.6 centimeters in greatest dimension, consisting of a nested neoplasm of monotonous cells with stippled nuclear chromatin and granular cytoplasm that stained positive for synaptophysin and chromogranin A. And I'm sure everyone here is knows where I'm going with this lesion, unless I lost you from the very beginning, but the mass is consistent with a neuroendocrine neoplasm. But the question that remains is, how do we classify this neuroendocrine neoplasm? And I'll be honest, I didn't look at it too closely, but if I had to do it just basically by Gestalt, I probably would call it a well-differentiated neuroendocrine tumor, but there are several easily identifiable mitotic figures that reached over 20 per 2 millimeters squared. And as I mentioned before, there was a high Ki-67, which then gets us thinking, okay, wait a minute, are we really dealing with a G3 well-differentiated neuroendocrine tumor, or are we dealing with a poorly differentiated neuroendocrine carcinoma? And so after trying to plug a way through, consistently getting that 24% of a Ki-67, we stained with the same panel of stains that I had mentioned before, where we performed ATRX immunostain, which showed retained nuclear expression, as well as we did RB, which in this case showed clear loss of expression within the neoplastic nuclei, with preserved expression as an internal control within the supporting stroma. And that overall is consistent with a poorly differentiated neuroendocrine carcinoma, and then based on the histologic features, large cell type. So how do I sign this case out? Well, it's a poorly differentiated pancreatic neuroendocrine carcinoma, large cell type, that actually extended into the duodenum, was 0.1 centimeters from the uncinate margin, as per the AJCC 8th edition. Anything or any tumor within a millimeter that at least is an exocrine type is considered a positive margin. So that unstable margin is considered positive. Poorly differentiated neuroendocrine carcinomas, again, are staged as an exocrine neoplasm. We did identify both perineural and lymphovascular invasion. There was metastatic carcinoma involving 4 of 24 lymph nodes. Overall, the neuroendocrine carcinoma, as staged as an exocrine pancreas, was a T3 and 2 neoplasm. So just to recap, some of the key points that we've covered in the session. Pancreatic neuroendocrine neoplasms are subdivided based on differentiation into well-differentiated pancreatic neuroendocrine tumors and poorly differentiated neuroendocrine carcinomas. When it comes to histologic grade, it's only applicable to well-differentiated neuroendocrine tumors that includes grades 1 through 3. Poorly differentiated neuroendocrine carcinomas can be further subdivided to small cell and large cell types. Further, the distinction between G3 neuroendocrine tumors and neuroendocrine carcinomas of the pancreas can be challenging, but critical for both treatment and prognosis. Therefore, for certain cases, I often use a limited panel of stains. If I have molecular testing, I would definitely use molecular testing. What should I do? But regardless, the stains are extremely helpful, and that panel, at least a minimal panel of stains, would include ATRX, DAX, P53, and RB. Finally, it's important to be cognizant of other solid lesions, either arising or secondarily involving the pancreas, that can mimic a neuroendocrine neoplasm of the pancreas that includes solid pseudopapillary neoplasms, acinar cell carcinomas, pancreatoblastomas, solid serous cystadenomas, those with and without mixed neuroendocrine, non-neuroendocrine types of epithelium, and finally, metastatic RCC, especially for the clear cell neuroendocrine tumors. And with that, I will end. And once again, thank you again for the invitation to speak today. And maybe next time I'll see you all in person. Thank you.